Hello, everyone. I'm Saleha, and this is Chai Chat and Community. Tonight, I have a very, very special guest, Dr. Samantha Pillay, joining me all the way from Adelaide. She has many, many firsts to her credit, and I will let her tell her something about herself before I start with all my questions. Hello, Sam, and thank you for joining me.
Hi, Salaya. Thank you for having me on the show this evening.
Pleasure. So, you're an awesome, awesome woman, including being the first urological surgeon in South Australia. Do you want to tell our audience something about yourself, please?
Um, well, I'll start with work. Yes, I'm a urologist or urological surgeon, which means that after medical school, I trained in surgery and the specialty was urology. Uh, and that was, it is a profession where there's a lot of male patients and a lot of male surgeons. And obviously, when I trained, the numbers of female surgeons were very low. And I was the first person to do that training program for adult urology in South Australia, in my state. And what happened was during that training, there was an area within that specialty of female urology, incontinence, and uh, lower urinary tract functional problems. And what fascinated me was it really didn't seem to get the attention, a lot of attention in our training program. There's a lot of focus on prostatic disease, prostate cancer, stones, kidney cancer, bladder cancer, and a lot of things people would have heard about. But this particular area didn't seem to have quite as much attention or recognition or training. And being the first female, I really felt a calling to sort of put my hand up and go, well, kind of as the first, this is the area for me to focus on. So I decided to subspecialise in that subspecialty of female urology, and I actually subspecialised exclusively. So since 2002, I went out into practice as a qualified surgeon, and all I saw was people under that subspecialty, and didn't do any general urology as well. And that's a little bit unique. A lot of people might have a particular area that they're interested in, but they'll still cross over with other areas.
Yeah.
So I established the practice called Continence Matters, and started out ambitiously on my own, thinking this area needed some more attention. At that stage, I didn't really realise just how big a problem it was, because it didn't get a lot of airplay even in medical school or training programs. So I kind of didn't realise that it was a big problem. I thought it was a really small subspecialty. But then, the practice will be 20 years next year, which is a bit exciting.
Wow.
And that there's now another 2 surgeons and 2 continence GPs who just do continence work and specialise in our area. They don't do the sort of usual general practice at our practice, and a nurse. So we've grown, and we still struggle to keep up with the demand. So I realised that it was actually quite a big problem. So that's, I suppose, who I am, what I do from a work point of view.
You do lots of stuff outside of work.
I do lots of stuff outside of work. I'm a single mum. I've got one son, he's 13. So that keeps me busy. I'm a businesswoman, so I actually own and am the director of the practice. So I have a very big role from the point of view of practice as well as my clinical role. And then, just because I didn't quite have enough to do, I have recently taken on a hobby of writing. And last year, or Christmas, so really just less than 6 months ago, I published a cookbook. And since then, I have been also doing more writing, which I enjoy, to try and keep me sane, and writing articles, which I publish online on my website and on another platform called Medium, medium.com, which some people may be familiar with, writers. So I've taken on a role of writing, and I'm sure there's many other things as well, but They're the probably
And
big hats that
your
I see.
your book is number one in the Amazon list.
It was very exciting to, in some of the categories, reach number one. So maybe after tonight it'll be number one again.
I'm sure
I
it will be.
I think with a lot of people, when not everyone, but I'm sure there's lots of people that sort of think to themselves, we really love to write a book one day. And I decided that, and with COVID as well, that helped when it came to writing, that, you get to a stage in life where you sort of think you better start doing those things. Like a lot of writers, I started writing a book never thinking that I'd finish it. And when I finished it, I never thought that I'd published it. And it was actually serendipity. I actually bumped into randomly someone who I went to medical school, which I hadn't realized had given up medicine, become an author, and started a publishing company, who helped me
Wow.
self-publish. And so I thought, oh, I can publish. And the the idea was to get it listed on Amazon before Christmas Day, so that I could kind of give it to my family, because I hadn't told anyone. My son knew and no one else knew that I was writing a cookbook, because I never really believed I was going to pull it off. And so, unlike other authors that publicise it and have book launches and things, and then, as I say, it started selling, and I've really enjoyed that side of whole new skills that has brought. And there's a lot of those skills that actually surprisingly cross over to surgery. So there's certain skills, I think, that have helped me become a better surgeon, and that have actually utilised directly in my work in surgery. So it is interesting. Actually, the one of the most recent articles that I've written, that people can look at if they want to, is the ways that writing has helped me become better at surgery. So my mental acuity, my organisation, my processing power, uh, things that I think slow down with age. And I was doing all those luminosity and Sudoku games and various things to try and keep active, but there's nothing
Yeah.
like throwing
Like
yourself into
writing.
a
Yeah.
completely new industry that you know absolutely nothing about, and having to learn from day one, which is kind of what it was like, back when I was at university and becoming a surgeon, to help. And being a writer, in actual fact, has, I've had quite a lot of interviews and online interviews, or television and radio relating to the book, and that's actually really helped in things like this. Someone asked me to talk about incontinence, and having done various interviews for the book really helps now when I'm communicating in the area that I'm passionate about, to talk about incontinence, having had that training. So I go into the article all the ways I think writing has actually helped directly in my surgery.
Great. Um, there is someone who says hello to you. Hello, Iftikhar.
Hi, Ithika.
Uh, so talking incontinence, can you tell us what exactly is incontinence in simple language, and why don't we talk about it? You've called it a Voldemort disease.
Yes. So what? So the Voldemort disease, again, relates to one of my articles, and there's so much stigma associated with incontinence that people don't want to talk about it. It's whether it's the general public, whether it's a patient that doesn't want to tell their doctor, but it's even the doctors. So it's so poorly addressed in our training programs in medical school. One of the questions I love asking when I ask medical students, in their 6 years of training, how much time do they spend on learning about urinary incontinence? And I'll be lucky if I get, half a day. Often it's like one
Wow.
hour lecture. And that is just amazing. So it means that a lot of the doctors don't want to talk about it. And it's not just medical school, it's general practice training. But even when you get to urology, I don't think it's given the weight that it deserves. So one is people not feeling equipped on the medical side to talk about it. Then you've got the patient not wanting to talk about it because of the stigma and the embarrassment. So those two things. So the reason I called the article Voldemort disease was it's like the disease that shall not be named. For all these reasons, people don't want to talk about it. But there was another layer to that as well, because the media aren't interested. There's all this talk about media, about mental health. People will talk about mental health. They'll share their stories. People make jokes about incontinence, but they don't talk about it in that in-depth way where they talk about how it's affected their life, how they've suffered, what it means emotionally to them. People haven't come out and talked and shared that just the impact it's had on their life. And we are seeing that now with mental health, but incontinence doesn't have the same attention. There's no celebrities, there's no royal family, there's no one coming out and talking about incontinence. So there is this sort of stigma. And part of the reason I titled that article Voldemort disease is because if I put a article with urinary incontinence in the title, I felt that no one would read it. No one would be interested in reading it. And so, yes, it is a bit of a trap, and I know you're not meant to do that, but I felt for a good cause to try and raise awareness by incontinence, I could have a title to try and get people to read on and find out what Voldemort disease was. So yes, I've taken a lens from Harry Potter because most people know that he is the one that shall not be named, and a parallel to incontinence. So the other part of your question, I think, was what exactly is incontinence? I've talked a bit about why people don't want to talk about it and the embarrassment. And one of the things I'll say first is that I see people with urinary incontinence. I specialise in incontinence. My practice is called Continence Matters. And I'll ask patients when they're referred, are you incontinent? And they'll say no. So it's not a simple question, and that getting that history and getting that information, getting someone to confide, part of it can be the embarrassment. But the other part of it is understanding what actually incontinence is. So some people will say no because they think it means losing the lot, and they have lots of leakages, but they want to downplay it. They don't really want to acknowledge it. And so they'll say, no, I'm not incontinent, meaning, and so what does that person actually mean by am I incontinent? And incontinence is any loss of urine that's not voluntary. So you're not actually at the toilet trying to empty your bladder. So it doesn't really matter how small. That's another question. That's a question of how bad it is, not do you experience incontinence or not. It's a when, how often, and how bad is the sort of follow on. So there are some people where they have a real continence problem, but they'll say even that they're not incontinent. And there's different levels to that. So sometimes I'll say, people say I'm not incontinent, and then I'll say, do you wear pads? And they say yes, and I'll say, how many a day? And they'll say 5, and I say, why do you change them? And they'll say wet. So I kind of know that even though they might have answered, there's more to the story. Then there's other situations where I could see someone and they'll say, no, I don't wear pads, and my underwear's never damp, but I really have to rush to the toilet. And I'll say, when you get to the toilet, say for a woman, if you're removing your clothing, pulling your pants down, they'll start to be that's so urgent, they'll actually start passing urine before they can sit on the seat, which could end up on the floor of the seat or just over the toilet. They're incontinent at the toilet or over the toilet. They can't actually sit and make that conscious voluntary decision to start passing urine. And similarly, I've had men where they would be incontinent, but they actually will have such urgency that they'll, pull over on a freeway or on a public place or urinate in a completely inappropriate place, in a building or by the road or in a populated area, because they can't hold on and they would otherwise be incontinent. So it can be a little bit of detective work, really, sometimes, especially when patients have different understandings of what urinary incontinence is, and adding to that, not wanting to tell you as well about it. And so sometimes and that's just that embarrassment. Sometimes you'll just get a little bit of a sneak of what's happening, and then as you build up a relationship and talk, a little bit more comes out, a little bit more unfolds, and they'll reveal that maybe there's more of a problem than they were willing to initially acknowledge.
Thank you. And Is incontinence common, and is there a particular age group that is affected?
Yeah, so it's incredibly common, and that's one of the reasons I'm so passionate about healthcare education, because one of those aspects that I was alluding to is making sure that a health professional feels really comfortable having that conversation and knows where to take it. They don't have one question, which is, are you incontinent, up their sleeve,
Yeah.
because that's just not going to get anywhere. And there are specialists like myself who specialise in the area, and there are specialist nurses and physiotherapists and GPs with a particular interest. But incontinence is so common that I don't believe it should just be those people with a special interest. It should be everyone. It
Yep.
should be anyone who, just like all GPs have education about diabetes and hypertension, because incontinence is more common than obesity, depression, cancer, hypertension, diabetes. I mean, when you think of that, and then you think of how much attention you hear in the media, or for health professionals, how much they get in their training, it's astonishing that this is somehow neglected. So if you look at, if you're asking about the particular prevalence, the age groups, when you look at young women who haven't had children yet, so there's a study showing 16 to 30-year-old Australian young women haven't had children, you're still talking about an incidence of 16%. So it's still significant even in that age group. It increases with age. Childbirth is a risk factor. So in women who've had children, 1 in 3 are incontinent, and then it
Wow.
increases with age. Once you're looking at over 50, so in the 50 to 59-year age group, it's 55%. It's more than 1 in 2. And then once you get to sort of, say, nursing home residents, you're looking at 80% over the age of 80. So it's astonishing how common it is, and how many people are affected. And you asked about affected, and I think that's a really important thing to talk about. And that's what people often don't talk about, and that's why I think there needs to be a lot more dialogue, is how people are affected, because people will talk about incontinence as leaking urine, having wet pads or underwear or outer clothes, but it's more than just leaking urine. Incontinence affects people's self-esteem, their ability to participate in the workplace, and therefore their earning that capacity, their ability for social activities, for sexual relationships. It can affect depression, social isolation, their ability to exercise, and then the implications on their health of ability to exercise. So incontinence has a huge impact on people, and that is ignored. People talk about whether or not people are incontinent or not, but the actual private suffering, the activities that people will give up. And actually, I was only having a conversation with someone the other day about this, in the sense that, women's role in society has changed and continues to change. There's been a lot of advances. I can sit here and talk to you as a surgeon, that in itself is part of that advancement, but there's still a lot more advancement. If you look historically, there were probably very similar prevalence rates of incontinence, maybe even higher, relating to traumatic childbirth. But women had limited roles in society. Now we expect to jump on a plane, wear fashionable
Yes.
clothes, participate in the workforce, sit through a business meeting. So our expectations as women demand that we have a bladder that works, basically.
Absolutely. Yeah.
We can't be housebound, and we don't want to be housebound, nor should we be housebound.
Yeah.
But the society's progression of women, it's so prevalent. If you think of, 50% of the women are over the age of 50, and increasing with age, it's so prevalent that this needs to be addressed for that cause. These pieces of the puzzle are all interconnected. And if I see girls that have dropped out of school and aren't going to school, or dropped out of university because of urinary incontinence, now the
Wow.
implications over a lifetime of something like that, when it's actually stopping an education or a workplace, just is the part of the problem that doesn't get the attention. People understanding the implications go far beyond the actual leakage of urine. Yeah.
Wow. Wow. Uh, so, what are the typical symptoms?
Um, so there's different types of incontinence symptoms. The other thing I should mention, actually, there was a report that a lot of people were talking that have talked about. There was one done in 2010, another one done in 2017, and when we're talking about the impact on a person and society, the other impact is on the economy. So, even if you don't suffer with incontinence, this is a big health issue, and we all want to pay attention to our health dollar. So the Deloitte Access Economics looked at just beyond those costs of healthcare. They actually looked at the loss of participation, the loss of wages, and as well as all the laundry and pad costs and the healthcare costs. And the annual cost in 1 year from incontinence in Australia, because it's affecting over 4 million people, is 42.9 billion was what they estimated as a 1
Wow.
year cost. So it's expected that it's going to affect by 2030, 24% of adult Australians will have urinary incontinence. These are huge numbers, and we can do a lot to save a lot of money by treating it. So that's another apart from people suffering. So it is something I'm very passionate about. There's a lot of work to be done. There's been a lot of work about other embarrassing things over the years. I mentioned mental health, breast cancer. I really think it's incontinence turn. We really need to make it our turn. So with these symptoms, so there's different sorts of incontinence. And so one of the things we talked about already was, is someone incontinent or not? And then there's questions, about how bad is it? And that can relate to how often it occurs, how many times a day or how many times a week, and then the volume of it. Does someone leak a few drops or teaspoon, tablespoon, cup? If they wear pads, do they overflow a pad, or their underwear or outer clothes? So we get an idea of how bad it is. And then how much they've restricted, things they've given up. If you don't do any exercise and never really exert yourself, you may have less symptoms than someone with a similar level of condition that's more active if it's related to activity. So when we talk about the symptoms, there are symptoms that are specific to types. So that's another important thing. There's not just one type of urinary incontinence. There's different types of different causes. They can have different symptoms and different treatments. So it's not like,
Everyone has the same. Yeah.
Yes, I'll have someone who they'll say, "Oh, I've got incontinence, and I heard my neighbour had this. Why can't I have that?" Well, you don't have that sort of incontinence, so it's not going to work for you. You have different sorts. So people might not realise there's different sorts. So if we start with the two commonest sorts of incontinence, one of them is overactive bladder or urge incontinence, and so that is a situation where the bladder is a muscle. So if you think of it like a balloon or something that gradually fills up with fluid, and then it's very passive. It's not really doing anything except expanding.
Yeah.
And then when you want to do a wee, it can just give you messages that you need to pass urine, and you can put it off for a period of time. Those messages might get stronger, but nothing really happens until you go to the toilet. Then when you're at the toilet and you want to pass urine, you allow your bladder to contract. Now, overactive bladder is where bladder is actually contracting. They've actually got bladder muscle contractions that are occurring. It's trying to push the urine out. It's no longer under the control of the brain. It's acting involuntarily. And so it's like you're at the toilet trying to do a wee, and all people can do is really squeeze their pelvic floor muscles to try and close the outlet so the bladder, when it's pushing, doesn't let any of the urine escape. So this particular problem, people have experienced urgency, that compelling desire to pass urine. They might go frequently. Their bladder capacity or the volumes that they can hold are reduced. They might get up at night. We call that nocturia. They're getting up at night to pass urine. And then urge incontinence is where they've got the urgency and they don't make it to the toilet and will leak urine. So those are the common symptoms we see relating to overactive bladder. The other main type of urinary incontinence that we see is stress incontinence. And people can have it both. They can have elements of both. So stress incontinence, and again, it's a really bad name because when it was first named, I don't think people talked about anxiety as much, but nowadays people think that it's somehow related to stress. It's not
Stress.
related
Yep.
to anxiety or stress in any way. It gets its name from physical straining or exertion. So when you exert yourself, there's an increased pressure in the abdomen, and normally that shouldn't push on the bladder. Well, it pushes on the bladder, but normally that pressure on the bladder doesn't allow urine to escape. But if there's some sort of weakness in the pelvic floor muscles or the sphincter muscles that are meant to hold the urine back, that actual pressure can then result in some urine to leak out. So the sorts of things, classics, things might be jumping or sneezing or coughing, star jumps, running. And they're the sorts of uh, sudden force or rise in pressure that can cause leakage. But there's levels of severity. So for some people that, it might just be rushing across the road or rushing to get the phone. It might be bending or lifting something. But it can be quite severe. So getting out of a car or stepping up a curb. And it can be so severe that even things like rolling over in bed or minimal activity can result. So the symptoms are a very good indicator, but they're not 100% what we rely. There are other things that we,
Really.
as
Yep.
surgeons, we rely on because there can be a mixture. You have to work out what's happening, and there can be crossover, and the symptoms aren't always correct in 100%. They're the two most common. There are other particular pathologies that people can have relating to, something more nasty or infections that could be caused transient, just temporary incontinence. There are people who it's actually more relates to a problem with their bladder emptying. So it's almost like an overflow. They're actually not emptying their bladder, and that's a factor in their incontinence. So there are other
That must be
less
painful,
common.
Sam.
Pardon?
I said that must be painful not being able to empty out your bladder. Wow.
Well, that's a really interesting statement, Celia, because in actual fact, it can be. So some people can have what we call painful retention, especially if it happens suddenly where they want to wee and it's dramatic and it's complete and they can't wee at all, and they usually end up in an emergency department needing a catheter. But there are other people where they might partly empty their bladder and leave some behind, and they can have symptoms of difficulty emptying, where they have to wait or concentrate or push or strain, or it stops, starts, and they feel that they haven't emptied. But in actual fact, there's plenty of people that have virtually no symptoms at all. They're totally unaware that they don't empty their bladder. That there are some people that might get infections or some other problem as a result of incomplete emptying, but there are some people that don't, and it can just even be found accidentally when they've gone to have a scan for something else, that they don't fully empty their bladder. Some people it's only a little bit and it really isn't causing a problem, but there are people, even those that have very little symptoms, that can have quite a major problem with bladder emptying. So it's quite a mixed group.
Wow. Uh, a few comments. Safdar Ali. Hello, Shapan. So this is a family friend from India who's watching. Thank you for watching. Um, Jaya. Hi, Jaya. Thank you for watching. So that was going to be one of my last questions of what Jaya is asking. Thank you for breaking the stigma. And question is, are there any preventative measures? So before we answer Jaya, shall we just talk about what should people do if they have incontinence, and especially women?
Um, yes, okay, we'll put that one on the shelf then.
Yes, we will
So
answer. Sam will answer your question, Jaya.
if people experience incontinence, what should they do? Well, there's interesting studies showing that 62% don't tell their doctor. They don't tell anyone. So the it's not going to get better unless someone does something, or you seek help. So the best person to speak to is your GP, your primary healthcare physician.
But
Uh,
you said GPs are not that aware either.
well, no, they are aware. They are aware, and that awareness is increasing. But there is, and there's a variability. There's some outstanding people who've got an interest in it. The question really is making sure that everyone has that uh, information they need and how far they can take it. Now, some of them may not have um, uh, the same level as someone else as far as managing that incontinence. They might be able to, but they should be able to refer or hopefully help that patient access someone who does specialise in that area. And as I mentioned before, there are a lot of people, whether it's other GPs or specialists or nurses or physios, they can help them access it. But what I'd like to do is see do everything I can to raise that awareness around amongst the broader health professional community, so that a lot more people can provide that a higher level of care. So talking to the GP is by far still the best thing, because they should be able to help you to their level of ability and put you in touch or seek help for whatever other areas, depending on how bad it is or their level of experience or access to treatments. So, and that can vary from country to country and, different regions as well. And just different people have different level of experience. If, someone has um, their first port of call doesn't have those skills, then they should be able to resource someone who's got an interest in it. There's, in addition to the GPs, there are continence physiotherapists and nurses
Oh,
in the community and attached to hospitals, and those continence specialist continence nurses and physiotherapists can also do a very good, excellent evaluation and provide non-medical treatment options for patients with incontinence, and will have a very good idea of when people need to see specialists or um, you know uh, engage with their GP as well, as far as other treatment for that person. So the uh, that that's what people should do if they experience incontinence. They should feel comfortable to talk about it, and that's a really hard area. I mean, I do remember a patient telling me, my GP asks me every year if I have a problem with incontinence, because it was on their sort of wellness check, and every year I said no because I was too embarrassed to say yes. And then one year when I was going away, something we all forgotten what that's like, traveling, they had more pads. They had a suitcase of pads more than their clothes, and they said, "I promise myself that next time he asks me, I'll tell him the truth." So these sorts of dialogues that people have in their head just show just how much that barrier is to facing the problem and admitting the problem, and um, I call it it's like a silent epidemic, isn't it? Really, just there in our society, having massive impact and on people's lives and on our healthcare system. So that's one of the things that people should do. There are things that, with the advice, people can do relating. So one of the things we talk about is avoiding caffeine. So caffeinated drinks can stimulate the bladder. They're
oh,
not the cause of the problem, they make symptoms worse. Bowel care, so looking after people's bowels, so they've got good bowel habits and avoid constipation, can improve people's bladder function. There are, and of pelvic for exercises, bladder deferment and bladder training exercises are the main treatments, especially that physiotherapists can help with. So those pelvic floor exercises are really important treatment, and probably leads us to your other listeners' question
Yes,
as far as prevention. So all of those things I just mentioned are treatments, but also preventative measures that you can look after. And I'm so glad that that listener has asked that question, because I, I really think that is the key. That is really important. We, like with anything, when it's massive, everyone's caught up in treating incontinence, but prevention is the key. And pelvic floor exercises, often the first a woman hears about pelvic floor exercises is when she's in the labor ward. Sometimes it's with her antenatal care. It's actually a pretty bad time, because there's so many other things as a mum that you're during pregnancy and when you've just had a new baby that you're thinking about. It's probably the worst time to try and
do
engage
pelvic
a
floor.
woman
Yes,
with pelvic floor exercise. They don't do them normally, and they're let alone at one of the most exciting but stressful times of your life. It's not a great time, and it could be started so much earlier. So that pelvic floor education could start in schools. Pelvic floor exercises could be taught to women early on. Pelvic floor exercises should really, I think, be like brushing your teeth. It should be something that people do lifelong. And the other reason that I think it's so important is that, our society now, maybe not us, but our kids, they're going to live to be 100. And
yes,
we're going to see so many health problems. I say health is the new rich. It's all going to be about what have you done in the first 50 years that's going to determine the quality of your life in the second 50 years. And if you wait until you're 50, it's going to be too late to make up that time. So I think that the first 50 years of people's life should be really focused on that prevention, because people are going to live longer, and we haven't seen that generation where people are we're already overwhelmed with chronic disease and multiple comorbidities in patients, that an extra 10 or 20 years of living with support, or uh, not able to care for themselves, or requiring massive drain on the healthcare system and cost. Prevention is really important. So I think the people doing pelvic floor exercises should be the ones that are not incontinent, as well as the ones that are incontinent. So thank you for asking that question.
So, Sam, before we wind up tonight's show, I have a quick question. So, amongst the many that I've already asked you, what happens if somebody is, say, 80 plus? If I was talking to my dad and asking, telling him about incontinence, because it's not really talked about, I'm wondering, what would I tell an 80-year-old person?
Yeah, so the same sorts of things. What's actually really happened over the last 20 years since I've been working in this area is the establishment of minimally invasive treatments, treatments that are therefore suitable to frail, elderly people with other medical illnesses that you may, think that it's not great to have an anaesthetic or a big operation. And one First of all, there's medication. So the overactive bladder we talked about, there's medication, and those medications have evolved over the last 20 years. And yes, there are some that still have side effects, but what's happened over the time is we've got better and better drugs that have less and less side effects. So there's medical therapy, definitely appropriate for that age group. If we look at overactive bladder, then one of the treatments that's used when medication isn't working is Botox injections. So botulinum toxin, just like people might
Wow.
have it in their face for wrinkles,
Yep.
you can actually have it injected in the bladder. So there's no cuts. You can pass a little telescope up the urethra, the tube where the urine comes out, that allows a needle to enter into the bladder and do a series of injections into the wall of the bladder. Now that can even be
Wow.
done.
This sounds so scary.
Yeah, and it takes about 2 minutes to do the actual injections once everything's set up. The actual, everything takes longer than that, but once you actually start injecting. And it's can be done completely under local anaesthetic. So people then don't need to fast. We have a situation where with our healthcare, we can offer people often their preference, their choice of local anaesthetic or sedation, but it's a day procedure. So if people are having under local anaesthetic, they don't need to stop their normal medications. I don't even stop blood thinners, which a lot of old people are on. So that's a minimally invasive treatment option. There's another way that we can try and regulate overactive bladder, and that is neuromodulation. What is that? That is where you use electrical stimulation to the bladder by accessing it through the nerves to the bladder. That helps regulate and reset and prevent these bladder contractions. So how do you deliver this electrical stimulation? Well, there's two main ways that we have currently available in Australia. One is a device that's actually implanted. So there's a little lead that goes in the back to the nerve in the sacral area, which feeds to the bladder. So you actually don't, the stimulation is not to the bladder, but the nerve to the bladder. And a little battery that's actually implanted in the body, so the device is internal, and it can be operated then with a remote control. Now, sometimes in elderly patients, so the overaged, that particular therapy requires some ability of the patient to understand the therapy and be involved in the therapy and operate the device. And that can be difficult in some older patients. It's not as effective, but there is an office-based form of neuromodulation that's quite appropriate in that and older. So the treatments we're talking about, even in patients in their 90s, not just in their 80s. So office-based neuromodulation, it's accessed through the tibial nerve, which is a nerve in the ankle. Okay. So using a little fine needle, like an acupuncture needle. In actual fact, if people want to see what I'm talking about, on our website for Continence Matters, so continencematters.com.
I'll share your website, yes.
Yeah, that's different to the one with the creative writing, which is Pillay.com, but the continencematters.com. There's a video of me doing the treatment on myself, so sticking the needle in my own ankle to show people. And then you hook up the little stimulator device, electrical stimulation for half an hour, so it's half an hour a week. And the initial course is usually 12 treatments, so once a week for 12 weeks, and then if it's working well, maintenance treatment. It doesn't work for everybody, but there's very little risk and not a lot to lose. It can be used, there's no reason, you can't use that therapy in conjunction with pelvic floor exercises and behavioural changes, dietary changes, even medication as well. So there are really minimal invasive treatments. For stress incontinence, there is even a procedure that can be done under local anaesthetic for that. So there's what we call injectable bulking agents. So people probably have heard of fillers. People have them in their face or their lips or something like that.
Everybody knows about fillers now. Yes.
Yeah. So it's basically when people have stress incontinence, there's not enough resistance in the urethra and the urine leaks out. So you can, again, put a little telescope in the hole the urine comes out that allows a needle to sort of go into the sidewall of this tube, and you inject the filler and it sort of expands it and helps block the tube a bit. And that can be done under local anaesthetic as well. So again, there are other treatments for stress incontinence. There's slings. There's been controversy and over the mesh slings, but there's fascial slings which don't use mesh.
There's a question on that. So yeah. I will first acknowledge my daughter's watching, so that's a first. No, that's not a first. Hello, Sammy. You're watching. Yes, she hasn't been watching for a while, so she's logged in today. Hi, Sammy. So here is Jaya's question to you. How safe are meshes nowadays?
Yeah, so this is huge. We would be talking all night. So there is a great government website and a lot of information available to Australia. There's actually on our website links to the government information on the website. There was a Senate inquiry in Australia over this. South Australia's just had another parliamentary inquiry over the use of mesh. And basically so I recommend people go and read that, because as I say, we could talk for hours just on this one topic. There were meshes used, so when we talk about vaginal mesh implants, mesh put in through a vaginal incision in women for the treatment of prolapse, the complication rates for that were incredibly high. And as a result, following the Senate inquiry, they were removed from the market and they're not used. The Senate inquiry felt that the mesh tapes or mesh slings for stress incontinence, so not for prolapse, for what we've been talking about tonight, the benefits outweighed the risks. The risks were there, but the rates were low. They weren't banned. They're still available. And it's a very complicated and lengthy discussion with any woman considering surgery to talk about the pros and cons and the risks associated with incontinence mesh slings, but they are an available treatment option, and there are benefits, which is why they're still discussed, relating to being a minimally invasive procedure. And so those need to be balanced. It's quite a lengthy conversation.
Conversation. Yeah.
When you're trying to advise other people, the things that are important to look at are the statistics, because that tells that person what their risk is. That's different to, so there might be a person that has an operation, and this relates to any operation, that has a horrendous outcome or dies.
Always. Yes.
Or
Yes.
Yep. And those operations, the whole operation's not banned based on that. No matter how bad that suffering is and how much support and help that person needs and how tragic the situation can be, whatever the treatment, whether it's, an antibiotic or surgery or whatever someone might have suffered as a result, then the statistics will look at that risk to determine whether it's still reasonable to offer it to other people. I suppose, the COVID vaccine is one of
Yeah, I
those.
was going to say that AstraZeneca. Yes.
Yeah, the government's recommending it for millions and
Yeah.
millions of people. So you have to look at the benefit outweighs the risks, and that doesn't help the person that unfortunate person who's had the complication. But those statistics are important. So when the Senate inquiry concluded that the benefits outweighed the risk, that should still be offered to patients. They are still available as well, but there are other treatment options. It's very important the patient looks at all the treatment options before they decide what's best for them. Yeah, it's a big topic.
Thank you, Sam. Thank you for answering all my questions. I have just learned so much, so many new things, and I'm sure I will call you up and ask you to come and do a follow up on that. Thank you so much for joining me tonight.
Thank you. It's been
Okay.
lovely to have a chat.
Same here. Thank you, Sam. Thank you again. Good night, everyone. Stay well, stay safe, and please wear masks. Victoria's back to lockdown. You know that, stage
I
4. Yep.
feel, oh my God. Anyway, we're going to get through this. Everyone's going to
Yes,
get
we
through
will.
it.
Stay safe, everyone. Good night.
Stay safe.
Bye.
Take care. Thank